All right, so today I want to talk about two different diagnoses, um, oppositional defiant disorder and conduct disorder. Um, these are the two most prevalent behavior disorders you're going to find with children and young adults. But I also want to tell you a little bit about some things that I use with clients with these disorders after we go over the DSM diagnoses and some differentiation. A lot of times, people see a connection between ADHD moving to oppositional defiance and then to conduct disorder and then possibly to something worse like criminal activity or antisocial, something like that. Many psychiatrists see a progression. Sometimes there is, but there does not always have to be. They're especially in that early diagnosis of ADHD. We're talking about severity with each one of these diagnoses. So a less severe criteria for ADHD certainly doesn't have to lead to a more serious diagnosis. A more severe ADHD, if it is, if there are interventions, both therapeutically and possibly with medication, it doesn't have to lead to this. So I just want to be a little more positive than a lot of the things that you might hear. I know the video that I posted is not that positive, but it was very difficult finding a video with these diagnoses, and those are kind of more severe cases that are a bit controversial, but might lead to some good discussion posts. All right, so let's look at oppositional defiant criteria. So criteria A, pattern of angry, irritable mood, argumentative, defiant behavior or vindictiveness lasting at least 6 months as evidenced by at least 4 symptoms from any of the following categories and exhibited during interaction with at least one individual who is not a sibling. Well, that was certainly me as a teenager and a lot of other teenagers I know. So once again, look at the severity of the symptomology. Angry or irritable mood, often loses temper, is often touchy or easily annoyed, is often angry or resentful. Argumentative, defiant behavior, often argues with authority figures, or for children, adolescents with adults, often actively defies or refuses to comply with requests from authority figures or with rules, often deliberately annoys others, often blames others for his or her mistakes or behavior. Vindictiveness has been spiteful or vindictive at least twice within the past 6 months. Well, and once again, it's a matter of the severity of the symptom. Criterion B, disturbance in behavior is associated with distress in the individual or in others in his or her immediate social context, family, peer group, or it impacts negatively on social, educational, occupational, or other important areas of functioning. A lot of times a school will refer a student and they'll get this diagnosis. Well, not all kids like school, and maybe not enough is being done to help them with that process in the school. I was a school counselor, and I had a lot of students who had this diagnosis, and yet I seemed to do okay with them. Criterion C. The behaviors do not occur exclusively during the course of psychotic substance use, depressive, bipolar disorder, etc. So specify severity: mild, moderate, severe. Associated features, and here they list problem in the family system. ADHD is common, higher degree in parents with a diagnosis themselves. Etiology runs in families, common in preschool children and adolescents, may be transient, problems with emotional regulation. So, of course, most children show an increase in disruptive behavior from late infancy through preschool years. That's pretty young. And once again, I would say, there is such a thing as the terrible twos. I'm going through that right now with my youngest. It's a matter of the severity of the disruptive behavior. Prevalence depends on gender, varies by age. Boys 3 to 5%, girls 3%, preschoolers 3%, adolescents 1%. I think preschool is pretty young to diagnose this. So a lot of really young kids are getting this diagnosis, and it kind of bothers me. Because a lot of kids fit this criteria, but in my mind may not fit the severity of the criteria. Let's look at the other diagnosis, which is a little more severe: conduct disorder. So a lot of times you'll see this transitioning, ADHD, oppositional defiance, conduct disorder, and it just keeps progressing. And parents often ask for some kind of help or intervention. And I think that everyone in the support system has to be on the same page. It really needs to be comprehensive in order for this to work. Criterion A: repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated. It's manifested by the presence of 3 or more of the following criterion in the past 12 months, with at least one criterion present in the last 6 months. Aggressive to people and animals. You will often see children hurting animals with this diagnosis, physically hurting other people, a destruction of property, deceitfulness or theft, and serious violation of rules, not just a breaking of some rules. Criterion B: disturbance in behavior causes clinically significant impairment in social, academic, or occupational functioning. If the individual is age 18 years or older, criteria are not met for an antisocial personality disorder. Then we have 3 subtypes: conduct disorder, childhood onset, prior to the age of 10. Conduct disorder adolescent, which is the most common absence of any criteria prior to 10, conduct disorder, unspecified onset, age of onset was unknown, degrees of severity, associated features. Individuals may show a lack of empathy or guilt, and I often think that there may be a relation between reactive attachment disorder and this diagnosis because of that associated feature. There could also be abuse of some kind, especially physical and emotional, possibly sexual, but there does not have to be. They may misperceive the intentions of others and see them as more aggressive than they are. They may have low self-esteem. There may be early onset of sexual behavior, drinking, drugs, combination of risk and impulsive behavior, including self-medicating. There's a higher degree of suicidal ideation. ADHD is more common. Very similar etiology, runs in families. Both genetic and environmental factors contribute to this. Youths often have first-degree relatives with histories of this disorder, usually have a temperamental characteristics that contribute. It's more common in males. There was a study done in New Zealand that showed that females could be just as aggressive, but they were not diagnosed to the same degree. So I'm not sure about the exact stats on males and females. Prevalence depends on gender, varies by age. Boys, 5 to 10%, girls, 2 to 4%, preschoolers, less than 1%, I would hope. Adolescents, 5%. So let's talk a little bit about some of my clients. I worked with students in the school system. I worked with children and youth. I worked with private practice. I've seen this in a lot of different areas. Once again, I felt it was overdiagnosed, especially, well, both of them really. And then at other times, it was a clear diagnosis because the symptomology was severe. For me, it was pretty clear whether this was diagnosable or not. The severity of the symptomology was pretty cut and dry for these two diagnoses. It wasn't just a child acting out or going against a parent or guardian or teacher's wishes or breaking some rules. It was more severe. There are often other comorbid diagnoses. Sometimes there is self-harm. Sometimes there is all of those things like drinking, drug use, tobacco, all of those things, sexuality, along with all of the aggression and other symptomology. I think the first thing I'd like to share is that in most cases, when I got a client, they didn't want to be there, no matter what the institution was. School, CYS, private practice, didn't matter. They didn't want to be there. I was seen at first as just another authority figure, just another adult that was going to lecture them. So the first thing I had to do was figure out a way to build some trust with a client that did not want to be there. So I brought it up. I'm like, I know you don't want to be here, and that's okay. And depending on their reaction, my response might change. I might be a little sarcastic. Yeah, I'd rather get paid and not be here as well, but we're here, you know. But I come right out and I say, I am not an authority figure in your life. And we talk about what that is. What does that mean to them? I'm not going to punish them. I'm not going to, get them in trouble. In fact, we begin to talk about what would they like changed in their life. I don't talk about what they would like to change at first. I talk about what would they like to be different. Well, they don't want to be grounded. They don't want to be on detention. They, whatever it might be, And I say, well, give me an example. Well, that gets them talking. And of course, there's a lot of blame. But I give them, some examples of, when I was a teenager, I was speeding and a police officer stopped me, and I was a smart aleck, disrespectful kid. I did not want to abide by the world's rules and regulations. So I got some tickets. Then I had to go take a class so I could reduce my points. And, but as I got older, yes, there's a safety issue in following driving regulations. And, but there's also quotas and, if you're in the South Hills, how many different police precincts are there within 10 miles? Everyone has to be funded in some way. So, we're talking about this with, the client and me. And I say, okay, so now I get stopped. And the first thing I do is admit my mistake and apologize for it. And I'm respectful and I call them officer, sir, or ma'am. And that sets the stage for a polite interaction. And I don't argue about my mistake. I readily admit it and apologize for it. And hand them all of my documentation, which is up to date. And I ask for leniency if that is possible. And I usually ask for it in a way that, I will accept, a ticket, whatever you see fit. But I'd really appreciate it if you could help me not get any points, because I can't afford a more expensive insurance. So I'm honest, I make a request, and I thank them. Now, it's not often that a police officer stops a person and gets thanked. And 9 times out of 10, they do give me a ticket, but they find a way to reduce any points. Knock on wood, haven't gotten any tickets in a long time, and I hope I don't. I live in Greensburg, which does not have any police. Hempfield. Hempfield Township does not have any police of its own. That was in the calculation of the move. But, so I'm talking about all this stuff with the client. Maybe I'm sharing a little too much with you, but that's okay. And then I ask my client, I say, okay, so who won? Who won that later interaction when I got stopped for a ticket? They think about it. And, they're like, well, I won. And I'm like, well, in reality, it was a win-win, what we call a win-win situation. Police officer didn't feel hassled, and they were still able to give me a ticket, but I won because I didn't get any points on my license. It was a win-win situation, and we want to make every situation a win-win. It didn't hurt me in any way to be polite, whether I meant it or not. I did mean it. I have turned into quite a polite adult. But I think that doesn't matter whether that client means it or not if they follow through with it. It'd be nice if they meant it, if they develop some empathy and courtesy and all those good things. We can work on that. Let's start with the behavior, because the less punishment they receive, the more they'll buy in to this process. My job, I tell them, is first to help to make their life a little easier. Aren't they tired of adults hassling them? Aren't they tired of getting in trouble? And I don't blame them for it. All I do is say I'll work with them to figure out some ways where it won't happen anymore. We can discuss it. It's not all going to happen at once. So, bonding at some level in a cooperative venture with the client, working together for a common goal. They don't want to be hassled. I can help them with that. It's not going to hurt them. The next thing, I try to figure out what their interests are. Do they have any? It could be anything from music to skateboarding, whatever. Even if I don't know what it is, I can probably look it up, figure it out, and have a conversation. Or I could ask them to share what their interests are with me. An example might be female client had a bag with Kurt Cobain's picture on it. I said, oh, you like Kurt Cobain, Nirvana fan. She says, yeah, well, you wouldn't know about that. You're not cool. You're just an old man. I'm like, really? What year was Kurt Cobain born? She's like, 1967. I'm like, pulled out my license. What year was I born? 1967. Me and Kurt would have been the same age if he hadn't committed suicide. Well, you got to be a little creative. Find some kind of bond. Doesn't matter whether it's music, art, comics, anything. Be creative. Let them know you're on their side, and I hope you are. That's just a little bit of what I do with my clients. It's just a start. But I found that often with these two diagnoses, the starting part is the hardest part, because it's breaking down those barriers. It's gaining a little bit of trust. It's helping them to become a little more emotionally vulnerable so that at least they'll have a conversation. That's the start. Okay.